Well, hello and welcome into Kettering Health Chats. I'm Dan Edwards, and we are live with interactive forum for you to ask questions of our Kettering Health expert tonight. And we're talking about what is causing your foot pain. We've got an expert here to answer any questions that you might have. Maybe you, maybe a loved one in your family who is suffering from bunions or, a litany of issues that can happen to your feet. We abuse our feet, no question about it. They get us everywhere we're going, and boy, when they go down, it's tough. It's tough to enjoy your quality of life. Now, as people are logging on to our Kettering Health Chats, we want to kind of set up what we're talking. Again, what's causing foot pain is our topic tonight. So for the next couple of minutes here, 29 minutes or so, we're going to be talking about that topic and learn about foot health and the tremendous impact it has on your life, and quite honestly, the impact it can have on your quality of life. Can you imagine going to Kings Island or any amusement park or vacation and not having feet that are healthy to get you around? It would certainly weigh you down and slow you down, no doubt about it. So we want to get to as many questions as possible. So fill up that chat box with your questions about foot health, and we will get to as many as possible. Of course, first come, first serve. So don't delay. Chat now. This is like a free consultation at home. You can't beat this, right? So let's now welcome our Kettering Health expert. It's Dr. David Welker. And Dr. Welker is a doctor of medicine from West Virginia University School of Medicine, dedicated physician specializing in orthopedic surgery. And Dr. Welker he focuses on foot and ankle reconstruction. He enjoys attending church, skiing, being outdoors, and probably hiking too, using those feet in a very positive way. Dr. Welker, thank you so much for joining us. We appreciate it.
Really appreciate you having me.
Hey, real quick, as people are kind of logging in here, share your journey with us. How did you get to become a physician with Kettering Health?
Well, I, as a little brother often does, followed his big brother's footsteps. And Mike, my brother, has been an orthopedic surgeon here in the Kettering Health Network for probably 10 to 15 years or so. And he's been really hounding me to come out here over the past probably about 10 years.
It's a good ambassador for us, huh?
Yeah. He gave it strong marks, and so he really wanted me to come out here because the network really needed to fill the void of a foot and ankle reconstructive guy like myself.
Okay.
So I finally relented after my girls went to college, and my wife and I were empty nesters, and a lot of other things, pieces of the puzzle had to fall into place to kind of even entertain the idea about moving out here. And when all of those pieces kind of fell into place, we kind of jumped on the opportunity, and it's been a great transition for me professionally to come here.
Oh, that's good to hear. Well, welcome to the community. And you've been here how long?
Started working in Kettering at the beginning of May.
Well, fantastic.
So just brand new. I still use GPS to get most every place I go.
Well, you said originally from Altoona.
Yes.
And so I'm assuming you kind of lean towards the Pittsburgh Steelers as far as your favorite NFL team?
Yeah, I lean stronger in the collegiate realm towards Penn State,
Gotcha.
but also my alma mater of WVU.
Right.
Definitely not Ohio State, definitely not Michigan.
All right.
As far as NFL goes, I just can't get used to the orange and black. It's gold and black for me all the way.
I understand, and a big Penguins fan, you tell me too. But
Right.
you got to get used to this, doctor. You got to get on board because Kettering Health is now the official healthcare provider of the Cincinnati Bengals.
I do realize that. I see it every day when I drive in. So yeah, it's something that takes a little bit of getting used to.
Are you enjoying your summer?
So far, so good.
Okay.
Yeah, we're trying
All
to get acclimated out here to the flatlands of the Midwest rather than the hills of Pittsburgh.
Yeah, we are rather flat compared to Pittsburgh. What a beautiful city that is. Another fun fact: this is your first Kettering Health Chats, right?
It is
Live. Okay.
Yes.
Well, we're great to have you. And listen, we got a couple of questions we want to lead off with. We have one that says, "I have pain under the second toe and a lump on the bottom of my foot." I know that's a tough diagnosis, but what do you think is going on here with Kathy?
Well, typically when there's a lump on the bottom of the foot, there's always a cause of that. So some people will get a big callus on the bottom of their foot, very, very common under the second toe. And usually what happens is the metatarsal bones, which are the bones that connect your toes to your foot, the second one is commonly very long. And when that's long, it does the lion's share of the work with regards to load bearing, and it's not designed to do that. That's not the way God designed our feet. So when that happens, as time goes on, the bottom of the foot thins out to some degree, and it leaves that metatarsal head a little bit more prominent. And people feel that. People often describe that as feeling as if there's a rock in their shoe, or feel like they're walking on a marble, or their sock is bunched up. So most likely, the cause of that is the thinning of the padding on the bottom of the foot, but also a prominent bone in the ball of your foot will then contribute to that and actually be the cause of that.
It kind of compounds itself, doesn't it?
It does. It does, because what happens is then the body tries to pad that, and it makes a callus, and that callus then accentuates that deformity, and it actually kind of builds on itself. So a lot of times we'll try to unload that with an orthotic, which is just an insert for your shoe. But then a lot of times, if that doesn't suffice with regards to alleviating the symptoms, then we'll have to operate on that and kind of shorten that bone down to some degree to try to take some of the pressure off of there.
Dr. Welker, do you see probably most like bunions or things like that, or do you get more serious cases that require, a lot of surgery and some rehab?
Yeah, I think I see a variety of different things. Right now, it seems as though I'm seeing a lot of significant deformities of the forefoot and the hind foot, and they require a lot more than just kind of shaving off a bunion. So I'm not sure whether that's going to be the pattern of my career out here, but it seems as though that's what I'm getting right now.
Okay. Cheryl has talked, she has a question. She says, I have a pain on my back heel up around my ankles. Can you shed any light there on what might be going on?
Yeah, so when you think about what can hurt, you got to think logically. And the anatomy in the back of your heel is probably some of the simplest anatomy of anywhere in the body. You really have your skin, then you have the big tendon that comes down the back of your heel called the Achilles tendon. And that Achilles tendon then hooks onto the heel bone. And a lot of times people will have a congenital deformity of the back of their heel bone that as they walk will kind of punch that Achilles tendon, which over time then will cause a little bit of a spur, a bony spur that protrudes out the back of the heel. And then what you have is you have a setup where you have a bony spur that is hitting against the Achilles tendon internally, and then you put a shoe on and you have the shoe hitting the Achilles tendon from the outside, and that's kind of a really good recipe for a lot of discomfort in the back of your heel. So that's what that sounds like. Most of the time people will complain of pain first step out of bed in the morning time when they get out of bed, and then sometimes that gets worse as time goes by.
So plantar fasciitis is something similar to that. It's attached to the Achilles, correct? That goes the length of your foot?
Right. I'm impressed with your anatomy, your knowledge. That's awesome.
Great for pre-interviews.
Yeah,
we do.
Right.
But seriously, that's a very common issue, particularly as people get older, correct?
Right. So yeah, the Achilles tendon, the actual plantar fascia is actually a continuation of the Achilles tendon as it extends down onto the plantar aspect of the foot. So they can complain very similar symptoms, just like Achilles tendon patients will complain. Pain is worst when you first get out of bed in the morning time. It may loosen up a little bit as the day goes on, but if you sit down and then take a little bit of a break, maybe a half an hour, or a drive to work or a drive to the grocery store, and when you get out of your car, then you have pain again. And so that's pretty much the way plantar fasciitis presents and the way Achilles tendonitis presents as well.
My doctor has told me when it comes to something like that you should, regardless, you should probably wear shoes around the house, like slide-ons or whatever, just to take away some of that pressure against your foot. Is that what you recommend as well? Just leave your shoes on.
Yeah, well, when you have pain on the bottom of the foot, any kind of padding that you can add would be helpful. And so barefoot walking with plantar fasciitis is usually pretty painful.
Yeah.
And especially if you're walking on hardwood floor or ceramic tile or linoleum or anything like that. So carpeted floor is sometimes good, or padding around the kitchen sink or something like that. But shoe wear, your shoes go where you go. So yeah, shoe wear would be the best thing to do for that.
And make sure you're wearing good shoes. And particularly if you're a runner or a jogger or anything like that, you should be swapping out those shoes fairly often, I would imagine.
Yeah, usually what I tell people in the office, if they're runners or walkers and they're doing that with any regularity, let's say 3 to 5 miles a day, 4 to 5 times a week, those miles add up.
Yeah.
And so I usually will tell people you shouldn't put any more than about 300 or 400 miles on a pair of shoes. Even though the shoe itself doesn't look worn out, the shock absorption component of that shoe will be completely gone by the time 300 or 400 miles rolls around. So if you're a walker or a runner with any regularity, those miles add up. You're doing probably between 60 and 80 miles a month. And that you should probably be switching those shoes out.
Okay.
Every 4 to 6 months, really is pushing it. And if you have a history of having some foot problems and some foot discomfort, I wouldn't push it to the end of that limit. You should probably go a little bit closer to the 300-mile range.
Okay. Hey, got another chat question here for you, Doctor. Deborah says, I mash my left foot outside between my heel and ankle. Blood circulation is bad in that spot, and it turns purple and swells, and I have had, I believe she says, Doppler and EMG tests with no results. Any suggestions here, doctor?
That's a tough one without seeing you in the office.
Right, sure.
If the Doppler test, depends on what kind of Doppler it is. There's a venous Doppler and then there's an arterial Doppler. An EMG, if the EMG is normal, then that usually means that there's been no nerve damage. Hard to say. Crush injuries are really challenging sometimes to get better. Those are tough injuries to get better from, and they usually do take a lot longer than just a sprain or a twist or a turn.
On the heel of that question, Catherine weighs in. Back to the plantar fasciitis question. She says she's had that for many years. Custom-made orthotics she has had. It helps, but she still has pain in her heels and ankle. And today her ankle feels bad. And she says it feels like a sprain, and currently icing it as much as she can. Any exercises to help, or do we need to now look at it might possibly require surgery at this point? Your thoughts on that?
Well, surgery is definitely the last ditch effort, particularly with the plantar fasciitis type of a symptom. So I go to great lengths to try to get people better with doing physical therapy, using orthotics, modifying the activity, inserts, a lot of different things that we try to do. There are some surgeries now that we've been doing over the past 10 to 15 years that are a lot more reliable with regards to lengthening the Achilles tendon to relieve plantar fasciitis. It sounds kind of counterintuitive why you would operate on the Achilles tendon when the symptoms are in the plantar fascia, but remember, it's one continual band of tissue. And so when you release the Achilles tendon, you loosen up that plantar fascia, which is been shown to be really helpful with plantar fascia patients. But still, the gold standard and the mainstay of treatment of plantar fasciitis and Achilles tendonitis is non-operative. It is only as a last-ditch effort that we even think about surgical intervention for that kind of a problem.
Well, let's talk about that, doctor, that threshold. When you're dealing with pain, it's not going away, you're trying to ice it, you're trying to elevate it, trying to stay off of it, but it's not getting better. Do we go to a sprain? Do we go to a fracture? We have a slide of a fracture. Let's show that and talk to us. Where is that threshold? What are we looking for, and how much pain, 1 to 10, should we be experiencing before we come see you?
Well, typically a sprain or a strain is going to require some level of injury. A fracture like you see on the screen there, that's a pretty good hit to get the ankle almost dislocated like that one is. So that's obviously going to cause a significant amount of deformity, significant amount of pain. I would argue, you're upwards of 8 or 9 on the pain scale with that one. So that's a no-brainer. That one you got to get to the emergency department, get evaluated, get that put back in place, and then probably with a fracture that looks like that, have that stabilized from a surgical standpoint. But sprains and strains, you know, if you twist your ankle, you can sometimes treat that with just, you know, the typical rest, ice, compression, and elevation, and you do that for a few days. Okay. And if that doesn't, you know, improve over the following 2 days, 3 days or so, then it's not a bad idea to at least, you know, counsel somebody to at least get an X-ray and see what's going on.
Yeah, Virginia says that she's been dealing with a strain, if you will, for about a year. And you have to wonder if maybe she needs to take other action toward this.
Yeah, I mean, it all depends on what treatment has been already attempted. You know, so a sprain, right, a lot of times we'll immobilize it in a walking cast boot or potentially a brace, maybe do some physical therapy, do a little bit of an anti-inflammatory, modify the activities to some degree. And then if that doesn't help, then you have to assess the actual stability of your ankle. And if the stability is a bit compromised and you're continuing to have symptoms, then it's not a bad idea to at least consider doing something from a surgical standpoint.
Yeah, I'm sorry, go ahead, Doc.
Now that threshold might be different in somebody who is, you know, Division I college athlete, sure, versus somebody who's a weekend warrior.
Right.
You know, so your phase of life has to factor into that decision making as well.
Sure. Doctor, this next slide, you talk about bracing the ankle. I mean, this looks like you've done a lot of work on this ankle. If you can show that for us, Chris.
Yeah, that is the previous ankle after we took that patient to the operating room. So the darker parts of that X-ray are where the plates and screws are that we put in there, and that acts as an internal brace. When the fracture is so unstable that an external brace won't hold those bones in place, enabling people to return to their normal quality of life, then we think about doing surgery. And the plates and the screws are actually an internal brace that we put right up against the bone, and we hold the bone in place with those plates and screws. And those plates and screws then act as an internal buttress so that the body can heal. Once the body heals that fracture, then those plates and screws really don't do anything. And so I usually will try to tell people, if you can't feel the plates or screws and they're not bothering you, I would probably tend to leave them in and just let them be.
Now, Linda says that sometimes when she walks, she says it feels like the bones on top of her foot shift, and then she has pain while walking. What do you think here, doctor?
Well, it all depends on the age. If Linda is middle-aged to kind of marching along through the wiser years of her life, then she probably has a little bit of arthritis in the joints in the top of her foot.
Okay.
So a lot of times, you know, wherever there's a joint, there can be arthritis. And so when you're walking, that force gets transferred through the metatarsal bones up into the arch of the foot. And so when that happens, those joints are not unlike any other joint in your body. They wear out. Our bodies break down as time goes by. And so if there's a prominence on the top of your foot where you feel like there's a bony spur, or sometimes there's a cyst or something like that on top of your foot, most likely that's as a result of having some arthritis in those middle joints of your foot. Mm-hmm. So if that's the case, then a lot of times we treat them very similarly. Like if you have knee arthritis, we'll consider anti-inflammatories, we'll consider cortisone injections. Unique to the foot, though, they do respond pretty well to orthotics, both over-the-counter orthotics and custom orthotics.
Now, Denise says that she has pinched a nerve in her back and that it is going down into her leg and foot. And she's had 2 injections in her back to help. Any ideas on how we can relieve Denise's pain?
Yeah, if the primary source, it sounds like if she's had an injection in her back, the primary source of her foot pain is actually coming from her back. And so if the injections in her back have given her good relief, then she might be wise to seek advice from a spine surgeon to see if there's a herniated disc that is causing that might be amenable to having surgery on.
Well, everything has to be in alignment, doesn't it? It's amazing what our bodies can do, but how they can feel when they're not in that alignment. Daniel says that he is experiencing intermittent burning and numbness in his right heel. Just his right heel, he says. What are your thoughts on that, doctor?
Well, again, that can be coming from your back. So that would take a little bit of a workup with regards to is it a nerve type of a pain, or some people will feel plantar fasciitis or Achilles tendonitis as a burning sensation as well. So hard to say exactly what that might be, but if it's a burning pain, that does bring into play a nerve type of an issue. So sometimes you have to get some studies to figure out exactly where that might be a problem.
Okay. Now you're going to have to help me with this, doctor, on this terminology. Marilyn says that doctors have told her that she has Cheblain's toes. I'm not sure I'm pronouncing that correctly. But
I'm sure I know what that is.
Okay, I'm not sure of that one either. Marilyn, we're sorry. I'm not quite sure exactly. Cheblain's, that's what it looks like how it's spelled. Chris, what would you say? About that same? Anyway, we're not quite sure what that is, Marilyn. We apologize. Certainly consult with your doctor as we move on. Real quick, we've only got a couple minutes left here, doctor. What's the pros and cons of ankle fusion?
So ankle fusion is done for ankle arthritis, which is not nearly as common as hip or knee arthritis, okay? So there's been a lot of work done over the past probably 15 to 20 years debating on the topic of whether you should do an ankle fusion or you should consider an ankle replacement. I have almost all of my career been a person who considers ankle fusion to be a very good, very reliable operation that does a good job of alleviating discomfort. Okay, so when I first started into private practice, 20, 25 years ago, we didn't even talk about ankle replacements because the design of the ankle replacements were not very good, and the longevity of that implant was very poor. And but that has changed over the course of the last 10 years. The designs have gotten better, the materials have gotten better. We're doing patient-specific implants now with regards to consideration of ankle replacements. So again, phase of life has a lot to do with the decision-making that goes into whether you would do an ankle fusion or whether you do an ankle replacement. Typically, the younger people, 20 to 50, that have arthritis, usually have a post-traumatic arthritic or a post-infectious arthritic process. And those people would be much more amenable to an ankle fusion just because the longevity of a fusion is permanent. Once it fuses for good. Now, the biggest knock of an ankle fusion is that you do lose motion, okay? But most people that have an ankle fusion have a very stiff ankle and have made all the modifications in the way they navigate their day and negotiate the terrain that they walk on to accommodate a fusion. So they typically don't miss motion. The other big knock against ankle fusion is the force that then was absorbed through your ankle joint has to get absorbed through other joints in your foot. And so there have been reports that years after an ankle fusion, the joint below your ankle or the joints in your foot can become arthritic, then necessitating further work. Mm-hmm. Now, with regards to an ankle replacement, like I said, the designs have gotten a lot better and the materials have gotten a lot better. So the longevity of ankle replacements are improving. They still don't rival the longevity of a hip replacement or a knee replacement. And so the older folks are better received with regards to the ankle replacements, just because they're not quite as hard on the ankle as somebody who is 20 or 25 who's a manual laborer.
Yeah. It seems like our children are beginning sports earlier and earlier. Are you seeing more injuries earlier because of that?
I don't know that I'm seeing more injuries because of the earlier start. I think what I'm seeing actually is the fact that kids are participating in sports 7 days a week, 52 weeks out of the year. They're really not offering their bodies a chance to recover. And so I'm seeing a lot of overuse types of injuries in the office, such as a tendonitis that typically younger kids don't get. I've seen a lot of stress fractures, stress fractures that can take a long time to heal. And kids feel like if they take time off to allow that to heal, then they're going to miss out or they're going to fall behind. And so I feel like there's this pressure now on kids that they have to perform at the highest level of any sport all the time, and they're going to fall behind if they take a vacation and go to the beach with their family. So I think it's important for kids and families to realize that our bodies are telling us something. When you get a stress fracture, you need to take a break, you need to back off. And kids are not immune to that. I'm seeing a lot of that in the office.
All right. But when I come in to see you, doctor, and we have to do a procedure, you're there with me pretty much all the way through rehab, aren't you?
Yeah, I think every provider is a little bit different. The way I run my practice is, I feel I'm responsible for your care. And so I see you preoperatively. I try to go to great lengths to make sure that you understand the procedure that we're planning, make sure you understand the recovery period. I operate on you, and then I see you post-operatively until you're through the whole process. So I feel like that people are putting their trust in me and not anybody else, and I feel like I owe it to them to do my best, and I can't do that if I'm not laying eyes on that patient.
Right. You are with Far Oaks Orthopedics, but you're officially in Sycamore, but you have really offices. Far Oaks Orthopedics have offices all over with the network of Kettering Health, don't you?
Yeah, we cover the southwest corner of Ohio pretty well. So I personally see patients in Sycamore Hospital or Kettering Health Miamisburg now.
There you go. Yep.
And then I also have an office in Sugar Creek. My partners go to those offices as well, but we also have offices over at Boonshoft, over at Kettering and Springboro, and so we cover the area pretty well.
What's the biggest issue with ankles and sprains? I mean, other than the fact that a lot of us are a bit overweight, is that a big factor? Just lose weight can certainly help your ankles and your feet.
Yeah, I think people that can take off a few pounds, really taking off that weight will go to great lengths, because when you look at the amount of force that goes through your ankle joint, estimates are that it's 4 to 8 times your body weight, per step. And so I oftentimes will do the math in the office. If you do a 10-pound weight loss and you just take the low end of that, that's 40 pounds per step. The average American takes about 5,000 steps a day. So with a 10-pound weight loss, you've saved yourself about 200,000 pounds per day.
That's amazing.
On your ankles. So you can talk about taking the anti-inflammatories, putting a brace on, and all those kinds of things. And not that those things are bad, but exponentially more powerful than that is your ability to lose weight and take some of the pressure off of your ankle for just joint preservation.
That's amazing when you break it down like that. Well, Dr. Welker, thank you so much for your time. You've been a delightful guest. Any other words of advice here during this summertime? As you know, let's be real. It's kind of open season for ankles and feet during the summertime, isn't it?
It is. Our kids are out playing outside. A lot more. They're not in the classroom, from 8 until 3, and so, just take care of yourself. be smart, wear braces if your doc has instructed you to do that. Make sure you're staying hydrated in the heat out there. And if you have trouble that lingers on beyond, a couple of days or a few weeks, we're happy to see you anytime.
Well, Doctor, thank you so much for your time, man. Some great information. We certainly see the passion in your voice, and we do appreciate you spending some time with us tonight. Thank you.
Appreciate you having me.
All right, hey, if you need more information, it's on the screen right there for you. Just go to ketteringhealth.org/ortho for more information and to connect with Dr. Welker. And join us for our next Kettering Health Chats live. We're going to be talking in August another important topic, back pain, with Dr. James Dunlap. Look for updates on a Facebook page. I'm Dan Edwards for Kettering Health Chats Live. We do appreciate your time and hope this has been beneficial. And again, if you have any information, just go to that website and Kettering Health Chats Live from Kettering Health. Yep, we want you to be your best. See you next time.